everyone. This is really live because we are in the middle of a vault where we have radiation oncology work, and our live is coming in and out. So do we have people on right now? If you can hear me and you can see me, please just write a comment and say, good to go. And then I'll introduce our speaker coming on. So if you're on, please just let me know that you can hear me okay. Otherwise, I'm going to keep trucking ahead, all right? We've got quite the show for you today. And again, I am here in the Cancer Center at Bighorn Regional Cancer Center, right across from West Park Hospital campus. And today we're going to be talking about prostate cancer. September is the month, correct, for prostate cancer? And so this is a really relevant topic for many of you out there, maybe for yourself or for a loved one or someone you might know. We're going to have our speaker, radiation oncologist, Dr. Lord, come on, and he's going to talk about what is prostate cancer, are you at risk, what local treatments are available, and what happens after cancer treatment. So all very great topics. And I don't usually do this, but I wanted to read Dr. Lord's provider bio to you because it's really special, and I think that you all should hear this. So, board-certified radiation oncologist Dr. Lord, who's going to be speaking, he respects each and every patient's hopes, values, personal experience, resources, and treatment goals. Modern medical care is a human undertaking that's complicated at times. He strives to educate patients and families about the diagnosis and process of treatment so the journey is understandable and less daunting. During a patient's journey, especially in cancer, his goal is to provide thoughtful and coordinated cancer care among the medical specialists that comprise a team so you receive the highest quality care. That to me just was awesome, and I would love to be receiving care here if I was going through cancer myself. I know the team here personally, and I'm really excited to have Dr. Lord come on and talk. We also are going to be joined with Cindy Glacier, who's going to talk about resources for you as patients at the end of this. Please let us know if at all you can't hear us during the presentation, so we're in loop in communication with you. And then also, remember, if you comment during the live video, your name will be put into a drawing at the end. So we'll make sure to contact you via Facebook if you're on during this. And then after this, we'll go ahead and load it also to YouTube. So if you want to share that with someone who's not on Facebook, you'll have access to this as well. Okay? So let's go ahead. I'm going to mask back up and have Dr. Lord come on. And he's got a great program for you.
Ashley. Take my mask off. I'm Dr. Lord, radiation oncologist, and as Ashley had said, we're going to talk today about prostate cancer, as it is Prostate Cancer Month. So we want to generate awareness. We want to make sure that people have, they are getting tested, and from there, we'll walk through, who's at risk, what the process is, kind of what we can actually deliver here at the Bighorn Basin Regional Cancer Center, and then basically where we're going from there, what happens after treatment's done. We'll do a small demonstration of the gantry that's behind me here, and just give you a little bit of an idea of how things go. But first of all, prostate cancer is a male-specific cancer that affects the reproductive organ, the prostate gland. The most common type of prostate cancer is adenocarcinoma. That is your 98% of the cancers that are diagnosed. We have other types of diagnoses that can occur, but this is what you're going to see. This is what you're going to hear of. This is typically physical examination. It's something where if there's an abnormal PSA and potentially okay. Sorry about that. Lost it. So once the diagnosis is established, there are multiple ways of treating prostate cancer. There's surgical management and non-surgical management. So today we're just going to talk about non-surgical management. with radiation therapy, and specifically external beam radiation therapy. So, taking a step back at diagnosis, you may ask yourself, well, am I at risk? Well, if you're an aging male, you're at risk. It's very rare to see prostate cancer in patients less than 40 years old, and typically as we get past 50, it increases significantly. 60, 70, 80 years old, I mean, as each decade progresses, we see a higher and higher incidence. Typically, people that are higher at risk, outside of the age and being male, we look at people who are of African American descent, Caribbean descent, non-Caucasian descent, just in the big picture of things. And that being said, there are things that you can do to minimize your risk as a whole, maintain a healthy weight, try to avoid smoking or don't smoke, and maintain a healthy exercise, and again, coming back to weight, I think those will be the things that you can do. There are dietary approaches that are really unproven in the big picture of things, so I don't endorse going to one thing or another. I try to take a middle road approach, and I think that's the way patients should really look at what can I do, what's modifiable, where can we go from there. But outside of that, when it comes down to treatment, and again, non-surgical treatment with what we do, typically when patients come to me, we would talk about what your risk is of recurrence, and that's based on your biopsy results. Why I might say you can go one way, you can go another way, or why, commonly I get asked, well, if you're recommending this, why did my brother or why did my dad or someone else get a different type of treatment? And so the treatments are really specifically addressed to the patient. So we again take into consideration best outcomes, but also what the patient's desires are for quality of life and so on. Here with external beam radiation therapy, we tend to treat over a period of 4 weeks. Okay, a lot of people will know and may know of people that have been treated over 8-9 weeks, and a lot of that is what we call conventional treatment. Here, what we've done is I've taken in most of the modern data, and I'm moving towards what's called a hypofractionation approach, where we can actually deliver the same effective dose over a shorter period of time. And typically, we don't see any increase in toxicity over the longer courses, and we have the same effectiveness, which we know that's out 10 years. So, we do that in a very focused technique, what's called intensity modulated radiotherapy, Imrt, or more specifically, VMAT. And the difference is subtle, but it's just an additional step forward in how we deliver treatment, allowing us to give a high therapeutic dose, but at the same time minimize dose to the adjacent organs. In this case, basically the pelvic organs such as the rectum and the bladder. Okay, so this allows us to decrease the significant toxicities that could occur otherwise, both in the early phase of treatment, during treatment, as well as after treatment, and something that can occur down the road 6 months to 6 years. Okay. Typical side effects that we see in prostate cancer treatment, if I were to give the most common things, I would say fatigue is common, but it's more of a lack of endurance that we see typically 2 to 3 weeks into treatment. It resolves in about the same time frame, and it doesn't mean you can't be active, doesn't mean you can't work out, exercise, whatnot. It just means that you're going to notice that towards the end of the day, you feel a little bit more tired, and if you're doing something physical, maybe you have a little bit less. Beyond that, when we look at, again, the toxicities, if I use my fist as an example for the prostate gland, really what happens is that the rectum is typically right behind it, the bladder sits right on top of it. And so with that, when we think about toxicities to the rectum, really what we see practically is that there's very little change in bowel function or bowel frequency or other types of symptoms associated with that because of this high localization of that radiation dose. We don't treat through and through the rectum anymore. We don't treat a lot of adjacent bowel that would affect how frequently you have a bowel movement or how loose it may be. So typically what we see is someone may change their frequency very subtly, if at all. And then with the bladder is basically something that it sits in contact with the prostate gland. And so to minimize radiation dose to that, we have patients come in with a comfortably full bladder. So a majority of the organ is away from the target that we're treating. So by doing so, we can minimize the short-term side effects of urgency to a degree. But there's still, because there's a contact patch, there's still a thank you. I think with the smoke in the air from the wildfires, I've got a little bit of a hoarse voice. So, but the coming back to the bladder, basically by having a full bladder, we maintain a minimal exposure to the organ, and then what that means is that there's still a little bit of urinary urgency. The urge to go to the bathroom is a lot more, it's stronger, but you can hold it. It doesn't affect continency at all. And so then from there, the only other area itself is the prostate gland. And the prostate gland itself will swell just a little bit during treatment because it's the target. And so with that, there's a capsule around it, and that capsule doesn't allow it to expand very much. And so what you see subsequently is that the urethra, or where urine's going to pass through, gets crimped down a little bit in some men. And it may be made worse by someone who has a very enlarged prostate versus someone who has a very normal or small prostate. So that's something that we monitor, but that can slow down urinary stream. It can even cause almost like a pinch-like sensation with urination. But it's something that, again, is temporary and resolves at the completion of therapy. So during treatment, this is a daily treatment. You're on the table, this under beam, typically less than 10 minutes, and most of that is spent getting alignment. And so we align externally to marks that are placed on the body, but then also in patients we use little markers that are placed inside the prostate gland before we start, and that allows us to actually localize the prostate gland down to very, very small margins. And so by doing that, we can ensure that we hit the target time after time after time. Okay, and so by doing that, again, we minimize, by being very accurate on the target, we can minimize collateral damage. Okay, so these are big picture things. So after radiation is done, after radiation is done, everything resolves pretty much within about 2 to 3 weeks. Now, mind you, there are some people that can have a longer course of side effects, and other people that can have shorter courses. So everyone's on kind of a spectrum. But the reality is that they should be minimal, and we shouldn't see a whole lot of long-term effects on the bladder or on the bowel. But things that we do see in patients, I would say the big things that we look for are potentially for rectal bleeding. And the reason for that is, again, if the prostate gland and the rectum share a space, that rectal wall sees radiation dose. And what may happen is capillaries may become a little bit more prominent in that area, and it may take up to 2 years to see that happen. And if we do, basically what you would see is if you had a bowel movement and you strained, or you had a constipated bowel movement, you might see a little bit of blood, like as in a bleeding hemorrhoid when you wipe. We manage that very similarly, and so it's minor in the big picture of things, where we see that probably in about 15% of patients. It's give or take, but the way I kind of explain it to my patients is, if it happens to you, it's 100%. We're gonna work through it and manage it one way or the other. Beyond that, from your bladder, I really don't expect any long-term residual bladder effects. But there are things that are very subtle that we may see on a urine test or something like that, where there may be little red blood cells or other things that we can see that show that there's been radiation change similarly to the rectum. It just wouldn't be as obvious. And beyond that, the other effect would be the effect on potency, or the ability to get an erection. That's something that it's, I would say as a general rule of thumb, what people come in with is what they will go out with, but it's something that we have to watch over years, and it's a subtle vascular effect, and we have ways of managing that, and I work with urology as well to make sure that people maintain quality of life and function. But that's where proper surveillance occurs afterwards. And so even though you complete treatment, in this case radiation therapy, we're checking your PSA typically every 6 months over the first 5 years, potentially annually thereafter as routine screening and surveillance. There are some patients that have other frequencies that are necessitated by the sort of the components of their disease, but that would be the normal routine surveillance frequency, and that can be alternated. In our clinic, I tend to alternate between urology and ourselves, or sometimes the primary care. So it doesn't mean that you're seeing 3 doctors for the same thing. We try to make it efficient for a patient in alternate appointments, and by doing so, we sort of maximize what we're doing and get appropriate surveillance and make sure that everybody's informed on what's happening. Okay, but I think that's a pretty good overview of the process, and even surveillance as a big picture thing. We don't typically need any post-treatment imaging. So up front we may do various imaging to improve our treatment planning, such as an MRI, but after radiation is completed, it has completed, I would simply say that imaging is not necessary unless there's a symptom that we need to work up would occur. Otherwise, it's really following the PSA trend. And I think, to put it in perspective, is that with when we look at the variation between surgical management and non-surgical management, with surgical management, the PSA drops to 0 immediately, or it should. And with radiation, we're waiting for those cells to die off because of the radiation effect, which typically we don't see a low point in that PSA curve for 2 to 3 years. So that hopefully can explain some of the differences when people talk to their friends, their colleagues and whatnot about the differences. Other things that can influence that would be the use of hormone therapy, or what we call androgen deprivation therapy, which will also affect the PSA value. But in the post-treatment setting, it is important to maintain health, a healthy weight, basically exercise. I would say, if we're trying to decrease risk of potential recurrence, cancer, and whatnot, I would say, just in general, I would avoid smoking at all costs. And beyond that, that's about it. There's no, I would not, again, endorse any special diets or any special supplementation, because the data is just sort of plus minus on it. And so I try to keep things as simple and straightforward for patients moving forward. So hopefully this has been helpful in the big picture of things. And I'm going to bring Matt in and see if we can't just demonstrate the movement of the gantry itself. So I'll remask back up. And so in the anatomy of a vault, this is what we call the couch. So this is what we call the couch, and so this is where patients are positioned. And typically we'll put some different immobilization devices that will help in making sure that the position is comfortable as well as repeatable on a daily basis. And then on the machine itself, we have the gantry where the beam actually is delivered from, and we have imagers on various sides that allow us to take either three-dimensional imaging, what we call a cone beam CT, or just plain X-ray films. So this is the basic anatomy of this, and I was going to say, I think that's probably all we have to show on that today.
So you kind of spoke to this, Dr. Lord, but one of the questions was, just the benefit of radiation versus surgery. You talked about the PSA levels, but is there a major benefit over surgery?
Well, I think I kind of, outside of different specialties, I think probably the the best way to describe the differences between surgery and radiation really. So I will take my general patient who is at a low risk for recurrence, someone who comes in with a low PSA, let's say it's less than 10. We'll talk about a Gleason score, which is a pathologic finding. It's how we describe the sort of aggressiveness of a cancer, but let's just say it's 6, so 3 plus 3, and those factors would say that these people have the best outcomes. In some patients, we can watch them. We can actually use active surveillance and keep an eye on them for years before we, may treat them or not. So, when I meet patients, what I find is that there's basically 2 basic camps, and that's one that is they will sleep better at night knowing that the tumor or the cancer has been removed, and I have others that, feel comfortable with let's say the response of radiation, meaning it does take time. We have to be patient. But at the end of the day, they would like to avoid surgical procedures. And so if I look at that big camp, I have that discussion up front, because when you look at those low-risk patients, there really is every option on the table, and they're equally effective. Just from a basic conceptual level, they're equally effective. And I think as you get further and further into more and more aggressive disease, then we start talking about more complex therapies, where it may be involving hormonal therapy to suppress testosterone, and it may be something where we're adding radiation, but we might be doing specialty radiation beyond just external beam treatment. So, but I think the first way to look at it is more, whether it really is how a patient's going to sleep better at night. It's are they comfortable waiting, or do they just feel better that they know they've gotten everything done immediately. So, but beyond that, I would have to defer to my urology colleagues about side effects expected with surgical intervention. So.
All right, thank you. I think that was it for now.
Okay, thank you.
Okay, next I have Cindy, and she's going to come on. She's with Wyoming Cancer Resources. Cindy has some wonderful resources for patients out there, anywhere from helping you find hair to gas cards to, she's going to talk about it. So I'm going to have her come on, and please, if you have any questions for Cindy as well, comment below. I see a few of you on there. Comment, and you'll be entered in for our little giveaway. So go ahead and come on, Cindy.
Perfect, thank you. It's a pleasure to be here today. Just talk to you a little bit about what Wyoming Cancer Resource Services can do for you. Your family or your loved ones, as you're looking for education or screening opportunities or help while you're going through cancer treatment. The Wyoming Cancer Resource Services Program falls underneath the Wyoming Cancer Program, which is run through the Wyoming Department of Health. And so my role in that is one of the 6 regional managers of the program. So I manage the Bighorn Basin. And so if there's anything that we can do for you, the best thing to do is just reach out to me. I am located here at Cody Regional Health, and my phone number is 578-2702. And I can provide education in a group environment, in a small group environment, one-on-one. We have educational materials, printed materials, or we can direct you toward webinars to help you understand any kind of cancer issues that you may be having. We have resources available to help with your screenings. We provide screening on the state level for people that are residents and meet income guidelines. Those income guidelines are very generous. For a family of 4, it's an annual income of about $65,000 a year, so that's a very generous income to fall within. The state will provide breast screening appropriate for your age, pap smears, or cervical cancer screening, and then also colonoscopies for men and women that are over the age of 50. So it's a really great program. You can find a link to that on the Wyoming Department of Health's webpage. And there's a shortcut, health.wyo.gov/cancer. So health.wyo.gov/cancer. or you can just go to the Wyoming Department of Health and find that information there. So it would be a pleasure to help you in any way that I can. We do have specific tools related to specific kinds of cancers, and I can't really give you hair, but if you are in need of a wig, I could probably help you with that. But anyway, I'd love to help you in any way that I can.
I think you all know what I mean by hair.
Of course.
So a lot of those resources, I hope I went ahead and wrote those in the comment area below. But please feel free to reach out to Cindy at any time. She's an amazing resource for our patients here. And you just never know if you're going to be going through cancer, or if you know of a loved one or friend who's going to have to as well. We have a big upcoming event now that we're done with our live talk here. I just want everyone to know that tickets are going fast. So please go ahead and just Google. It's called Rocktober, Rocktober. I think I spelled that right. But just Google Rocktober in Cody, Wyoming. We're going to have music, s'mores, chili dinner, rock climbing, cash bar, hot cocoa, hot apple cider, goodies.
Music?
Yeah, lots of music. There's going to be a wonderful event going on Friday, October 9th, called Rocktober, from 5 to 7:30 p.m. So if you and your family want to come, it's $25 per carload. So load up your carload for $25. Come and get dinner and some goodies, and we'll have our live auction and raffle at the same time. So again, that's Friday, October 9th, and just Google Rocktober in Cody, Wyoming, and get your ticket fast because they are going quickly. So we've got 60 spots available. But thank you so much for listening. And if you're watching this at a later time, just feel free to reach out to us, and our team is here to help you, and we'll see you soon.